Hi, my name is Tamara Rodriguez Rugel, and I'm going to talk about pediatric outcome after maternal cancer diagnosed during pregnancy. About the definition, among women in whom cancer is diagnosed during pregnancy, factors such as maternal illness, diagnostic tests, cancer treatment, and increased levels of maternal stress can negatively influence fetal development. Cancer treatment during pregnancy exposes the fetus to potentially toxic substances that influence cell division. Chemotherapeutic drugs can cross the placenta in varying amounts.
After my obstetrics residency, I went on to do a fellowship in high-risk obstetrics to take care of pregnant women with different medical disorders. And I encountered 2 pregnant women diagnosed with cancer who were advised to terminate their pregnancies. And I realized that their oncologist had not met a pregnant patient before, and their obstetrician had not met a cancer patient before. And I realized there needed to be an expert in the field of both of these specialties to help the oncologist deal with the pregnancy, to help the obstetrician deal with the cancer, and to help these women remain healthy enough to have a healthy child and to be there to care for their family. Pregnant women come to me and asking what is maybe safe to be treated in pregnancy. The last thing I want a pregnant woman to do is deny herself treatment because she's worried that it's safe for the baby. I keep a registry of pregnant women diagnosed with cancer and keep a record of how they were treated, how they were diagnosed, and I look at their children long-term on a yearly basis to see how they're developing. And I have the ability to share with pregnant patients diagnosed with cancer who feel they may be the only pregnant woman ever diagnosed with cancer, that there are almost 400 women enrolled in the registry who have been diagnosed and treated for cancer during pregnancy. And if we can show that the children are developing normally despite receiving chemotherapy during pregnancy, then the pregnant patient diagnosed with cancer will have that option and not feel the need to sacrifice her own treatment for the safety of her child. There's nothing more gratifying to me than telling a pregnant patient with cancer she doesn't have to terminate her pregnancy. And not only that, but she can be safely treated for her cancer and be around and healthy to care for her child. I would like a pregnant woman to know that she can access the expertise we have here at Cooper for treating cancer and pregnancy while remaining with her own obstetrician and oncologist she feels most comfortable with. I have often consulted with physicians not only in the region, but in the world about safely treating cancer during pregnancy. At times it's difficult to specialize in cancer in pregnancy. Just when I think it's too much, I will walk into my office and see this wall of women who were brave enough to take care of themselves and to receive cancer treatment and live long enough to have their children and take care of that child as well as other children they may have. And these women inspire me every day to continue doing what we're doing and following these children so that I will never have a pregnant patient say, I will sacrifice my own treatment in order not to expose my child.
Applications in medicine. Data on fetal effects of maternal cancer treatment are based mainly on retrospective cohort studies. From 10-year experience, it appears that the limited availability of safety data can influence therapeutic decision-making, which results in a high threshold for initiating chemotherapy and a low threshold for terminating pregnancy. It can also delay maternal treatment and result in preterm induction of labor. Limited data are also available on prenatal exposure to radiotherapy. The International Network on Cancer, Infertility, and Pregnancy published combined prospective and retrospective data from a multicenter study involving children who have prenatal exposure to chemotherapy. Our initial data seemed to suggest that fetal exposure to maternal cancer treatments was not associated with cognitive or cardiac abnormalities. About the study, a total of 129 children in the experimental group were matched with 129 children in a control group. Results: 79 preterm, 11 very preterm, 16 moderately preterm, 52 late preterm, 50 full term. The number and type of congenital malformations were similar to those in the general population, and the results of neonatal neurologic examinations were normal.
Thank you for giving us the opportunity to share with you the most important data in a nutshell on a study we call the outcome of 129 children after antenatal exposure to cancer treatment. And this is a case control study conducted by the International Network on Cancer, Infertility and Pregnancy Registry. In the first interim analysis we published 3 years ago, there were two negative aspects. We did not have a control group, and we included children of 18 months until 18 years, so the age distribution was quite high, and that's what we wanted to improve in this study. And as you can see here, we included 129 children born to mothers with cancer with pregnancy, and they were matched in 1-to-1 with 129 control children born from the general population. There were 89 children exposed to chemotherapy, some with surgery, 4 to radiotherapy, some with surgery, 7 with chemotherapy and radiotherapy with or without surgery, which means that 96 children were exposed to chemotherapy, 11 to radiotherapy, which means that in total 100 children were exposed to chemo and or radiotherapy. But 1 child received trastuzumab, 1 interferon beta, 13 children surgery only, and 14 children, in fact, there was no cancer treatment, but there was cancer diagnosis, there was the stress during pregnancy. What did we do? We looked into the general health. We did a general pediatric and clinical neurological examination, and there was a general health questionnaire for the parents. We looked into the cognitive outcome. We did do the Bayley scales of infant development, the 2nd or the 3rd edition by a psychologist, and we looked into detail in the heart morphology and heart functions by doing an echocardiography and an electrocardiography. Looking into the postnatal growth, we see at the left males, at the right females. We look into the length, is the above curve, into the weight in the middle, and the head circumference at the bottom. And as you can appreciate, actually most of the values in fact fall between the 5th and the 95th percentile. In the study, 61% of the children was in fact preterm, and 22% were actually had a weight lower than a 10th percentile, which is in fact a double as what you would expect. But of these children, 64% actually had a catch-up growth until normal growth measures. Looking into the general health, there was, we looked into incidence of medical problems.
Pros and cons. About pros, this type of study allows to make appropriate therapeutic decisions. Another pro, the results show that treatments for cancer during pregnancy do not cause significant effects in children. About the cons, it should be taken more importance to make this type of studies and to do it in other populations to show if the results are maintained.
Treating pregnant women who have cancer is complicated, and it can endanger the health of the mom or baby. But a recent study has some promising results. The study found that children were largely unaffected by in utero chemotherapy exposure. They also showed no long-term developmental or mental delays. We spoke with Dr. Sarah Temkin for some perspective on the study. Dr. Temkin is a gynecologic oncologist at the University of Maryland, and she wasn't involved in the study.
When a young woman has cancer and is pregnant, it gives you a second patient to think about, which you not only need to think about the delivering optimal or the best possible cancer care to a woman, but also being mindful and respectful of her wishes regarding her pregnancy. And at times that means a patient chooses to terminate a pregnancy, or at times that means making sure that both the mother and the fetus are safe. The cancers that I take care of as a GYN oncologist, the mainstay of surgical treatment is a hysterectomy, which is obviously not compatible with maintaining a pregnancy. So in the cases where a woman, for instance, has cervical cancer and finds herself to be pregnant as well, there are choices to be made in terms of the optimal timing of delivery versus delivery of chemotherapy versus delivery of radiation, and a woman cannot receive radiation or surgery to her pelvis at the same time as she carries a pregnancy. However, in the case of breast cancer, which was really nicely shown in one of the Lancet articles, a patient can safely receive surgery to her breast or mastectomy even, and also receive chemotherapy, which are the mainstays of treatment of that cancer. Interestingly, in the articles, in the Lancet articles, they talk about targeted therapies, which are really, I think, the new frontier in treating in cancer treatments, and none of those treatments are really right now compatible with pregnancy or safe to give during pregnancy, and so.
About issue obligated in Ecuador, there are no records of similar studies conducted in Ecuador. The mentioned study was made in a collaboration between national referral centers in Belgium, the Netherlands, Italy, and the Czech Republic, all members of the International Network on Cancer, Infertility, and Pregnancy.
Hello, my name is Dr. Peter Frederick, and I'm a GYN oncologist at the Roswell Park Cancer Institute in Buffalo, New York. A GYN oncologist is a cancer doctor that focuses on treatment of cancer of the female reproductive tract. Today we're here to talk about cancer and pregnancy. The three main kinds of treatment for cancer that we employ in general are surgery, chemotherapy, and radiation therapy. And so each of these three things can have an effect on the mother, of course, and also on the unborn baby. Well, I think it's important to avoid things that are known to have toxicity, and I think you can group that into several different categories. When we're trying to diagnose cancer or diagnose the extent of cancer, a lot of times diagnostic procedures like CAT scans and X-rays and ultrasounds and MRIs are used, and it really depends on the kind of cancer and the symptoms the patient is presenting with. But we want to avoid unnecessary radiation exposure to the fetus when we're doing our diagnostic procedures. Also treatment of cancer as well, and so we want to avoid the chemotherapy or the other drugs that are known to have toxicity. And in some cases, if the cancer is diagnosed at an early stage or if the pregnancy is very far along when it is diagnosed, we want to delay those treatments until after delivery that can be safely delayed. And sometimes if a treatment involves both surgery and chemotherapy, we may do the treatment in certain orders in order to spare the fetus any unnecessary toxicity. The most common cancer diagnosed in women in pregnancy would be cervical cancer, cancer of the cervix. That's the lower portion of the uterus or womb. And the second most common is probably breast cancer. And that occurs in maybe about 1 in 3,000 pregnant women, so very rare. About a third of all cervical cancers are diagnosed in women under the age of 35 in that childbearing age. And as women delay childbearing until their late 30s, 40s, sometimes even their 50s, as women are having babies older and older, the rates of some cancers can increase. Because of many of the normal changes that occur in pregnancy, sometimes it's more difficult to diagnose a cancer if it occurs. I think that if you're talking about breast cancer, for example, if there's a breast mass, because of the normal changes in the breast that occur during pregnancy, sometimes it's more difficult to feel a breast mass, or sometimes the mammogram, which is used to diagnose breast cancer, is less sensitive. So pregnancy does add special challenges to diagnose.
In conclusion, the rate of cancer increased with the pass of the time. A very complicated situation is to have a disease like this in a pregnant woman. Normally, a woman in that situation tends to have fear and confusion. because most of people do not know if a treatment can cause or not a negative effect on the baby. But thanks to studies like this, women can know that she can receive a treatment, and the statistics show that babies do not present significant negative effects. On the other hand, a topic like this needs more attention, and similar studies need to be made in all the countries to help the mothers to recovery of their illness and have their babies at the same time.
It was around October of 2013. It was my second pregnancy, my second baby, and I noticed lumps starting to form in my neck. And I went to the GP, and he put me on a waiting list and said that I'd be seen to in the new year. And lumps kept forming, and so it became obvious there was something wrong. And the obstetrician scheduled for me to go to some tests with the endocrinologist. And that's when I first heard the words, "We think it's cancer." I just couldn't believe it. I couldn't believe that I could be pregnant and have cancer. It just didn't seem possible. When I was first diagnosed, the doctor said that we are going to treat your case as a two-patient model because you are pregnant and there's another person involved. So they were there to give me the very best treatment, but to also protect my baby. So for instance, when I went for my CT scan, they had me covered up, my abdomen was covered by a huge sheet of blocking material so that my baby would be protected from radiation while I got the necessary scans. I was stage 4 lymphoma, which meant that the cancer had spread from my lymph nodes to my liver, my lungs, and my spleen. So the doctors needed to act immediately. It was an urgent case. I had to get the treatment right away. I was diagnosed on a Friday, and that Tuesday they had me in getting chemotherapy. And I got amazing treatment. I mean, from the obstetricians, from the oncologists, from the hematologists, everybody around the board gave me the best treatment. I was extremely happy at such a difficult time to be surrounded by such professionals and competent people. It was great. The whole issue of abortion never came up. They knew that they could treat me and also maintain, the health and safety of my baby. And they knew that even though there were small risks to my baby, they were still going to treat me with the most aggressive cancer treatment that is available. I never once felt that I was being treated in any way less than anybody else or any other cancer patient because I was pregnant or because Ireland had banned abortion. Throughout my treatment, I knew that the doctors had put a priority on me and on saving my life. Because if I wasn't alive, then certainly my baby wouldn't be living either. There was no compromise in the treatment that I was given. I was given the best treatment, the treatment that anybody else who had cancer would have been given. I know that there was an abortion law.
Thanks.